Well, thank you, Danielle, for the welcome, and thank you everyone for having me tonight. It's an honor to be here. And in fact, some of the programs I'm probably going to touch on tonight, either myself or Chief Tobin, some of you might be very familiar with and even have some additional information or perspectives to provide. So in addition to time for question, I think I speak on behalf of both Chief Tobin and I. Please feel free to chime in, to add anything as we go, or to, I don't know, the best kind of technological process, raise your hand or jump in if you'd like to add anything or add any perspectives from some of the work you might be doing that touches upon some of these programs. So happy to have this be as interactive as I guess Zoom will allow. So I'm just going to share my screen. Okay. All right. Hopefully that's look okay, big enough or clear enough. Okay, great. So yeah, I've had the honor of working.
I'll just have you of the.
Okay, that work?
Perfect.
Okay, perfect. Thank you. Oops, but then it keeps going. Okay, so stop. Okay, so I've had the honor of getting to work with Chief Tobin on a number of initiatives over the past couple of years. So I was really excited to hear that we'd be able to present together. So some of the information, certainly I'll be handing the baton over to her, but there'll be some overlap. So also Chief Tobin, if anything I'm touching on, if you want to add in anything at any point, feel free to, and I'll, do the same. So I'm going to start just by talking about a general overview of kind of the current state of New York City's behavioral health crisis services. And I think some of this will probably be no new information for some of you, but I imagine for others, it might be just a helpful overview. This is kind of like an ever-changing landscape. Thankfully, both nationally and locally, there's been a lot of attention being paid to the improvement and expansion of behavioral health crisis services, thinking about new ways to meet the needs of individuals at kind of all levels of crisis. Like the word crisis could mean a lot of different things to a lot of different people, and thinking about wanting to make sure that it's not just an outpatient clinic or an emergency room, and thinking about all of the different steps in between that can help meet individuals' needs. And in my position with Office of Mental Health, we're seeing increasing collaboration with OASIS to think about, kind of whole person care and not as much of a segmented mental health, substance abuse treatment, and then seeing increasing collaborations with other agencies that are involved in crisis, NYPD, EMS, FDNY, DHS, Department of Homeless Services. So it's really been an exciting time to be doing this work. And I'll tell you a little bit about kind of current services, and then if we have time, a little bit about future directions. So I kind of just grouped together the, current services, main services that are currently part of kind of the New York City continuum. And I'll walk us through those piece by piece. And again, you can feel free to stop me at any time, or we can answer questions at the end. So I would imagine most of you are familiar with NYC well, either professionally or even just like the advertisements that you see. And I think where NYC has gone over the past couple of years is really helping to kind of formalize a crisis hub of sorts for New York City, in that they not only offer kind of the free texting or chat or call line support with crisis counselors and peers, they offer peer services and peer support as well, but they also are now engaged in the triaging and the dispatching of mobile crisis response. Additionally, they play a role in screening and potential linkage to co-response, which Chief Tobin will talk about later. And they actually work very hard, more regularly even than annually, to be updating a centralized database of behavioral health services. So this is not just crisis specific. But for example, when I was at the Bellevue Cpap, like every 6 months, we would get a call or an email asking, what kind of services are you providing? What type of eligibility criteria are there? What type of openings are there? Those kind of questions that they're asking regularly. What kind of insurance do you accept? So just as like a provider, it's a nice thing to know, I think, for, individuals that you might come in contact with or that you might be treating that you think might benefit from a higher level of care or a different or an additional service. It actually, is a great resource for practitioners as well as patients or individuals in the community. So, and that is, the database is available not only like online by kind of searching through that, but also you can call. Prior to the pandemic, they were averaging a little less than 40,000 calls a month, and it's growing. I mean, I think that some of the role that they were looking to play was not only for the crisis kind of call support, connections to treatment, referrals, and the centralized database, but ideally also doing some follow-ups. But I think the recent kind of increase in calls that are coming in has even limited their capacity to grow in that way. So I think it is increasingly, especially with all the stress of the pandemic, proving to be a really important resource. So in terms of, I think I did, the Cpap. So I'll start with this. So NYC, well, you guys are probably familiar with, and, I think it is, the last thing I just wanted to say about that was that it is not a substitute, of course, for if you are providing care to a patient. It's not a substitute for obviously the care that you would provide, but I think it's a nice resource.
Uh-oh.
Okay, I think we had some technical difficulties with her freezing. Let's see if she restarts. She restarts. If not, we might be able to try to switch the order of presenters. So
let me pull this back up. I just wanted to keep everyone in suspense for the next portion. Okay.
Well, you were quick in your return, so thank you.
Right. So the Office of Mental Health recently updated the regulations for Cpaps for the first time in many years. And so there's some minor changes, more substantive changes, but where we are right now is the three main components of a Cpap. So there's the traditional Cpap, the actual emergency service where you're, performing triage, assessment, crisis intervention. Then you have your extended observation beds where you can hold individuals for up to 72 hours for observation and treatment. And then you have crisis outreach services. So historically, this was actually categorized a little bit differently and involved like a crisis residential kind of bed component. But now the goal really is to think about those different levels of care and really helping to encourage Cpaps to not only have mobile crisis teams, which they all do, but to really grow kind of interim crisis or follow-up crisis services. Seeing such a kind of cliff when people are leaving Cpap and then where are they going, and really trying to prevent the revolving door that happens sometimes for individuals that really don't otherwise or can't otherwise engage in community treatment. So thinking about additional services besides mobile crisis to help to support individuals or link them into care. And I just kind of a little summary, because I know even for myself, it's a little dizzying to remember who's a psych ED, who's a Cpap, et cetera. So mobile crisis teams. So as I mentioned, has an associated mobile crisis team. There are also community-based mobile crisis teams. For example, like visiting nurse service is one. And for those that are not that familiar, the way that mobile crisis works in the city is that every mobile crisis team has a catchment area, which has been divided up based on volume and based on geography. And so for any one team, they have the same catchment area kind of day in, day out, where they'll be seeing individuals. And over the last couple of years, the referral process has changed a little bit. So there's a centralized referral process for mobile crisis teams, and it is by calling NYC Well. So that's like, I think, helpful for us to be letting our patients know, letting their families know, and then, for us to know as well as providers if we are alarmed or if we have concerns or are not able to reach an individual that we're working with and we have reason to believe they might be in, distress or at risk. The calling NYC Well is kind of the centralized way to activate a team. You don't have to be looking up like, well, this patient lives in this area, so which mobile crisis team would it be and how do I reach them? And I think those are the kind of obstacles that historically could sometimes trip us up. And so I think it's really nice that we can know we're calling NYC Well, and then they will help to triage it. Is mobile crisis indicated? And then, they will send out to the appropriate team for who should be responding to the call. The most mobile crisis teams, not all, but most still accept internal referrals. So if you work as like part of a hospital system and the patient you're seeing is well known to your hospital and you really, even though they live further away, you really want your mobile crisis team to go, you can still contact your own internal service as well. But I think the more centralized process seems to be working well, because one other thing I'll mention is that since the start of 2021, we have prioritized the goal for the mobile crisis teams is to really try to respond to most calls within 2 hours. And that's a big shift because up until last year, the average response time, depending on the borough, was anywhere from about 14 hours up to 24 hours. And so without a ton of new resources or staffing, the teams have been working really hard on trying to kind of optimize their processes to respond to those calls coming in kind of right away or as soon as possible to be able to kind of just keep moving ahead with things in a timely fashion. And the teams generally are operating 8 a.m. to 8 p.m. 7 days a week. So we're not having, evening overnight coverage. We've been trying to look into that. It's very challenging in this climate, especially with workforce challenges, to be able to recruit and retain people wanting to work in evenings, overnights, in all settings. But that is a goal to try to have that 24/7 coverage eventually. Mobile crisis teams are staffed by mental health clinicians as well as peers, and that's also been a goal for 2021. Role of peers on the teams. I think, as most of you know, they provide crisis intervention, de-escalation. They help with assessment and referral and linkages to treatment. Mobile crisis teams can actually visit up to 3 times. So if either they're not able to meet with the individual at the first visit, or they meet with them and they determine that, they are ambivalent about treatment, or that the team feels like they need to try to build more rapport or need more information for their assessment, they can visit up to 3 times. And the clinicians are trained in 958. And so if they do meet with an individual and determine that they do seem to be at elevated risk and would benefit or need a hospital assessment, then they are authorized to remove. I'm sure all of you in the forensics know. And if for New York City, like the process of that would be that the team then, if the person is willing to go, willingly, then they may just, go with them. But oftentimes 958 might be activated when the person is not willing to go. And so the 958 is activated, and then the team calls 911 and then coordinates actually with NYPD and EMS to bring the individual into the nearby Cpap. So if anyone has questions about mobile crisis, but just keeping an eye on time, I'll move on. So crisis residential is another kind of part of that crisis continuum that I at least didn't have as much familiarity previously. They were historically called crisis respite, and there were a couple of programs throughout the city as part of the parachute programs in the past. But the exciting thing is that OMH in the past year developed regulations and is working on licensing these programs to allow them to not only expand, but to bill for their services so that they could actually be more self-sustaining, because they are rather resource intensive depending on the type. And so the traditional model, which is now being called crisis residential support, is a model where individuals can stay up to 28 days. It's an open voluntary setting, so people can, go on about their activities of daily out as they choose. There's not, any sort of limitation. And it's actually more of a peer-led model. And so there's not as much treatment occurring on site per se, but there's a lot of support and linkages to community treatment and helping individuals navigate things, either pre or post-crisis. The two new models that have been developed from the Office of Mental Health is the intensive crisis residence and children's crisis residence. So these will be hopefully being developed over the course of the next year. We already have a couple of agencies that have, have agreed to take this on, and they are in development. The intensive crisis residences will differ from the crisis residential support in that there'll be on-site treatment available. So it's a more treatment intensive. And then, of course, the children's crisis residential will be specific for the child and adolescent population, mostly the children population. And I think now more than ever is really going to be a critical piece in this puzzle, offering a less kind of restrictive option for individuals that are in crisis. And I will say that recently NYC Well, we had NYC Well adding the information about crisis residential. So if you do have someone that is in distress and you think might benefit from time away from wherever the setting that they're in is a trigger for them, you could certainly, they or you could call and get information about this. And one thing that we're trying to do is have more up-to-date bed availability information so that, if someone is interested, you don't want them to be then calling and going through the process of potentially, trying to get accepted and then learning that there's no bed, there won't be bed for, 2 weeks or something like that. So right now there's not that many beds across the city. It's limited capacity. So we're trying to make sure that they're used to the best of everyone's ability. So at the end of this presentation, I just left a slide for future directions. So maybe we can circle back if we end up having time, but we'll hand it over to Chief Tobin, and I think Dr. Kleinman might be doing a bit of an introduction.
And I think even before we go there, if there is any specific questions for Dr. Goldman on the points that we've already addressed about the current.
Oh, I think, Danielle, you might be muted.
No.
And Chief Tobin, I meant to say that I will forward the slides if you want to just let me know, next or whatever, and I can press the buttons.
Sure. Thank you. Danielle, you're good.
Okay. Was there any questions that anybody had that they wanted to in the interim?
Not yet.
Okay, otherwise I'll pass it over to Dr. Kleinman.
Hello, everybody. Boy, we really are honored tonight to have such prominent speakers. So first of all, thank you to both speakers. I'm very excited to listen to our next speaker, and I simply am going to read Chief Tobin's bio directly, since I have actually never met her until this evening. Chief Tobin joined the NYPD in 1983 and began her career on patrol in South Jamaica, Queens. She was promoted through the ranks to her current title of Chief of Interagency Operations, overseeing and facilitating the NYPD's transition of certain to other appropriate primary agencies while maintaining support for those missions through a public safety scope. Additionally, Chief Tobin oversees the Behavioral Health Division, which works with components of the criminal justice system, other government agencies in healthcare, mental health advocates, and community members. Chief Tobin earned a PhD and a Master's of Arts degree in criminal justice, a master's degree in social work, and a Bachelor of Science degree in sociology, social work. So another underperformer amongst us. During her career, Chief Tobin has received numerous honors and medals, including the NYPD's Medal of Valor and a special congressional recognition in honor of her heroism, bravery, and sacrifice during the tumultuous events of September 11, 2001. She has been a New York State certified social worker since 1985. Chief Tobin is also a graduate of the FBI, the Police Management FBI Academy, the Police Management Institute, and Harvard University's Senior Executives in State and Local Government program. So again, thank you, Chief Tobin, and I turn the floor over to you.
Great. Thank you so much. And thank you, Dr. Goldman, for doing the slides as we go. Before we begin with the slides, I just want to put in context the number of calls that come through 911 for that are categorized as people in crisis. In 2020, we had over 160,000 of those calls, which I see some of you saying, wow, it's less than 4% of the calls that actually come through the 911 system. And the vast majority of those calls get directed to the hospital. The officers respond, as well as EMS from FDNY. And I think oftentimes there's a misconception that we have criminalized mental health and we arrest. Less than 1% of the people that we encounter as a result of these calls winds up in an arrest. And what's important to note there is when officers respond, and suppose someone has taken a brick and thrown it through a window, and the owner of the property is there, and they want the person arrested, that is the complainant's right to do that. So I would say in the vast majority of all cases, the NYPD treats these calls as aideds first. We certainly don't think that the criminal justice system is the correct venue for people who need help. But oftentimes they're unfounded, or the person has gone on arrival. Because don't forget, these are people possibly calling from their cell phones. They see someone directing traffic. We arrive, there's no one there. And 15% of these calls wind up in a non-crime corrected. So we get to the corner of 125 and Lexington Avenue, and there is someone there directing traffic. And we go up and we say, we actually hire traffic agents to do this. And although we appreciate your work, you really don't have to do that. And the person just voluntarily, goes on their merry way. So that's what the category of non-crime corrected. But as I said, the vast majority of the cases wind up with a transport to the hospital, which is very important when we talk about be heard, because there's more alternatives to do that. So I just wanted to preface that. So Dr. Goldman, I'm ready to do the slides.
Thank you. I'm just trying to, for some reason, I'm getting a host disabled participant screen sharing. So I'm just trying to figure out how to get the screen back up.
Allison, are you around to help with the?
Try again now.
Oh, now I got it. Okay, thank you. All right. Okay, great. Okay, great.
So the first program I'm going to talk about the Support and Connection Centers. We collaborated with the Department of Health and Mental Hygiene to open 2 Support and Connection Centers. And it's DOHMH that actually holds the contracts, who have worked through the staffing and the model and the best practices nationwide. So one is opened, it became operational in 2020. And as you can imagine, it shut down in March of 2020. But it's run by the nonprofit Project Renewal, and it accepts referrals from the precincts that are in the immediate vicinity of the center itself. Samaritan Daytop will be the operator of next next Support and Connection Center, which is scheduled to open in early 2022. For us, it serves as an alternative to hospitalization and for non-emergency mental health issues and or substance abuse. And what's great about them is that they're 24 hours a day, 365 days a year. And we're able to transport people when they voluntarily want to go. And there are certain things that we don't necessarily know. So there are times when we bring someone and drop them off, but they get rejected. And like an example is perhaps they have very high blood pressure. Or another example is when they're doing the physical exam, they see many open wounds and they have to go to a regular hospital. But in any way, it's been, it was opened in February. It closed from March 18th to October 27th of 2020 due to COVID. And then it reopened on October 28th with a limited capacity. And I think the numbers are on the next slide, Dr. Goldman. This is it, right? There's an integration of telehealth on overnight hours. The overall center has been reduced to 20 from 25. Overnight stays capacity was reduced to 10 guests. So our officers actually call before bringing someone there to make sure that there's room. There's COVID screening upon arrival. There's a mandatory mask policy. And we have referred 135 unique individuals to date. What's important to note is that once we bring you there and you become a client of the Support and Connection Center, you don't need the police to bring you back again. So, and the one on 116th Street run by Project Renewal is really, it really is gorgeous. They've done a very good job of making it welcoming. And it's decorated and very homey. So I believe that as we move along, they're going to continue to have a lot of success in that area. So next, I'm going to talk about the Be Heard pilot. So it stands for Behavioral Health Emergency Assistance Response Division. And anyone in city service knows everything has to have an acronym. So that's the acronym for this program, which was launched on June 6th of this year. And what it does is it sends mental health teams instead of police to respond to nonviolent, non-critical 911 EDP calls. So it teams 2 FDNY EMTs, paramedics, with 1 mental health professional, and that is a social worker from Health and Hospitals. It originally was operational in the 2.5, the 2.8, and the 2.3 precincts. And one of the reasons why we selected that area is because it gave the Support and Connection Center as an option for calls there. In November, just last month, it expanded to the 2.6 and the 3.0 precincts. And if you can see from the map, it just shows you where in Manhattan. It's Upper Manhattan. It's they operate the teams 7 days a week from 9 a.m. to 1 a.m. And those hours were based on the data of the calls that we had previously received in on 911 our call takers. Okay. So here's a picture of the kind of truck that they go out. This truck does not transport, though. I want to be clear. It is full of a lot of equipment that they may need, but it does hold the 3 people that are assigned to the truck, or the ambulance for the tour. To date, they have handled 21, 7 and 8. So instead of having a police response, which would be the default, suppose they're out on another call, we will go back to the traditional way of responding, which means that a radio patrol car and an ambulance would respond to the call. Within the first 3 months of the pilot, they released the stats from June 6th to September. The 91% of the people accept from the Be Heard teams. 48% resulted in a transport to the hospital, 25% were assisted on site, and 18% were transported to a community-based care location. And one of those, among others, would be the Support and Connection Center. I'm going to talk about the co-response team now. This has been operational since March of 2016. It's available on 2 tours, 7 days a week. We originally started at 7 a.m. and went until 11 p.m. We subsequently changed the hours, which I'll speak about, but we turn out 3 cars, up to 3 cars per tour, which has 2 officers and 1 clinician, that is a Department of Health and Mental Hygiene employee. So there's daily roll call on cases. Now, it's not a 911 response vehicle. These are people that we get referrals to, I should say referrals on, from a variety of sources. And the example I'll give is a shelter may call and they'll say, Terry Tobin, has been living in our shelter, but, last week she got verbally abusive with the staff. And then last week, she came back late and she was agitated. She picked up a chair. She threw it and hit the wall, but didn't hit anyone. So that there has to be some type of escalating violence, as well as some type of mental health. Referral meets that criteria. We consider that pre-crisis response, and we will deploy on that person. And then we do follow-up responses. These are people who we know, say, were removed from their home. They were taken to the hospital, but they have since been released. We go out just to make sure that they have remained connected to services. The whole part of what we're trying to accomplish with this unit is to integrate crisis services. Rather than having people go through the criminal justice system, we want to work with mental health and get people connected to the appropriate services that they may need. It was briefly suspended for in-person deployments from March of 2020 due to COVID, and it resumed at the end of August. But from January 1st of 2019 to December 31st of 2020, 78% of the clients, and what we do there is we go back X amount of time prior to us getting engaged with them, and then we reflect the same amount of time after we've engaged with them. And we've seen a 78% decrease in police interaction within the 3 months after the case deactivation. So it's effective in the sense it keeps people in the health lane and not in the criminal justice lane. Next. This is our triage desk. So this is actually where the calls come in. And you are all more than welcome to call. We get referrals through New York City Well. If you have any questions or you have direct referrals, we'll be glad to take them. It's 24/7 since October 2018, and it's NYPD officers and clinicians that have access to their respective databases that accept the referrals, and then based on the outcome of those deep dives on someone's history, we develop a strategy to respond, but it may not always stay with co-response. We can respond and say this person is more appropriate to mobile crisis, and we'll confer with them. Or there's these HEAT teams, which are purely clinicians with no officers. The clinicians staff the desk remotely, except on the midnight hours. We keep it 24/7 because we do get calls. My next evolution is that we would have real-time data so that when we're responding to, say, a jumper on the Brooklyn Bridge, it would be really helpful if we could have the health information for our emergency service unit to say, listen, we're reaching out to the person whose care this person is under to see if we could have a effective resolution for that. They started hybrid staffing the model from 7 a.m. to 9 p.m. in September of 2021. mentioned before that we were doing it on 2 tours, but work until 11 o'clock. The reality is that we weren't knocking on doors after 9 o'clock at night. So we thought it was more appropriate to, in the middle of the day, when we're more likely to see people, or at dinner time, to change the hours so that they would be available to deploy then. Next. This is the crisis intervention team training, which I don't know if you're familiar with, but and if you have not had a chance and would like to see it, the new police academy, it's in College Point, Queens. It moved from 20th Street between 2nd and 3rd in Manhattan to, it was probably a landfill before they built the police academy, but it's huge. And before they put the roof on, they put in vehicles. There's a lot of mock environments, as you see in this photo, but you know, they set up an actual housing authority apartment. There's a bodega, there's a bank, and it's wonderful training because it's more adult-based for the officers while they're going through the training academy. But our crisis intervention team training is co-taught by police personnel and clinicians who are contracted through CUCS. We have been doing it since June of 2015. There have been close to 17,000 NYPD members trained. It was put on hold again with in-person learning in March of 2020. But it's a 4-day course. And what happens is in the morning, the clinicians teach what are some mental health concerns and what officers may encounter on the street. And then in the afternoon, they come back and they do scenario role plays in these mock environments. We've also included mental health consumer panels, which really valuable interactions for officers to hear firsthand what people's experiences, whether it's negative or positive, in terms of their own experience with law enforcement. And they also do a piece, an example I'll use is MP3 player. When they do the module on schizophrenia, people work in teams, so they have them put the MP3 players in, and then in a very simple voice like I'm speaking now, we ask their partner to tell them to go put a piece of paper in the garbage, and they can't manage having different directions. So I think it builds empathy, but I think it also stresses what it might be like for the person. So, you know, the idea of saying, drop the knife, drop the knife, drop the knife 500 times probably is not the most effective way for us to be telling someone to drop the knife. So it's a way of saying, are you hearing any other voices but mine? You know, can you focus on me? So they do a wonderful, wonderful job. And the people who act out the behavioral health diagnoses are professional actors, like they're members of SAG, and they are unbelievable. So it has received very good reviews from the people attending, and I think it's having a positive effect on the street as well. And then the next slide, I just wanted to this was the reason that we created it, was to assure the safety of people with mental illness, for the police officers responding and for the public, to safely and effectively address the needs of persons with mental illness, to divert people with mental illness from the criminal justice system when appropriate. And I would say that's the vast majority of times. And then save the human and financial costs of criminalizing people with mental illness, and hopefully link people to, like with Be Heard, to community-based services to promote recovery. Those are our ideal goals. So that's what the NYPD is doing in terms of people in mental health crisis.
Thank you, Chief Tobin. That was wonderful. And I don't want to monopolize the many questions that I would like to ask, and just open up the floor to questions of Chief Tobin and really both speakers at this point.
And Dr. Goldman, if you wanted to address those two future directions points with 988 as well.
I mean, I can say a word or two about it and then make sure and then leave the rest of the time for questions and if we have time at the end. But just to kind of put on everyone's radar, if you've heard or not heard about 988 coming down the pike, it's a national behavioral health crisis line that's going to go live in July of 2023. And so there's a lot of work that we're doing statewide and then also locally to be planning for this, whether that's with Chief Tobin and others thinking about how the interaction between 911 and 988 with DOHMH about, what this means for NYC Well. Luckily, I mean, I think a lot of the infrastructure is in place as a result of NYC Well already being here. So I think that is another piece where there is going to be ongoing kind of behavioral health and police collaboration, thinking about the 988 rollout, and then the development of crisis stabilization centers, which align somewhat with what Chief Tobin was mentioning about the supporting connection centers. So I think that's one other piece of the puzzle that New York State doesn't have is at least in a standardized form, crisis stabilization centers, 24/7 open access centers where people can self-present, be referred to get essentially urgent care treatment if they need for mental health, needs. The two kind of directions for this, at least as far as OMH is concerned, for like licensing and billing, there'll be a living room model that's a peer-led crisis stabilization kind of setting, and then a more intensive treatment setting where this is a collaboration between OMH and OASIS. So being able to provide, immediate mental health crisis for detox or any other immediate needs. And what's, that also comes into play with police in that we've heard feedback that it's, for those centers that are currently operating, that having a specific police drop off at these centers is really important to help encourage that police can easily link individuals to the services if they need. They're not going to be waiting online at a door or having to go through and spend, hours waiting for some sort of handoff. So all of these centers will have that in mind and having that kind of separate entrance, easy access. So there's really no wrong door if an individual is, involved with police or otherwise, and it's determined they'd be better suited to receive mental health treatment, they can just be dropped off. So that's it.
So thank you. I saw a few questions come in the chat, but to make it more interactive, if people do feel comfortable asking their questions out loud, that would be great. I guess just to start, I'll throw it to Dr. Capasso for her first question.
Great. Thank you, Chief Tobin and Dr. Goldman. What a fantastic presentation. I work at Project Renewal, so we work at the Supporting Connection Center and also in charge of mental health for our mental health DHS shelters. My question is, there's so many great resources, and often if I get pulled in for a complicated case with one of our folks experiencing homelessness, our frontline staff who are RAs, they maybe have, a college level education at best, don't really know how to triage. So should I call 911? Should I call the co-response team? Should I call mobile crisis? And so I know how to answer those questions, but I guess for a lay person, how would you recommend when they're worried about somebody, how to access these services so that it gets triaged to the right team?
So Dr. Goldman, I'll take a shot at answering that. I think that if there's no imminent risk of harm to the person or the surrounding people, I think I would defer to New York City Well, because I think they ask the appropriate questions and they have the global picture of what's available. And I think they do a very good job at providing the referrals that are needed. And it's an easy number in New York City. We actually have cards that we give officers to give to people to call themselves.
I would agree with you. And there is a kind of handoff if needed from NYC Well to 911. So if in the midst of the call, NYC Well saying, actually, from the sounds of it, this sounds, really emergent or dangerous, I'm going to transfer you over. There's not at this time the reverse, where if someone's calling 911 and the call receiver says, actually, this is not an emergency, I think you should go to, but that's where that's happening. Those discussions are happening. And I think that's a big piece of this, especially with like 988 in mind. People are saying another number, like you expect people that are in crisis or are caring for someone in crisis to then somehow navigate a system in minutes and know. So I think it really should be the responsibility of like the call takers and the system to develop these algorithms that no matter where someone calls, there's going to be communication between those different layers, and that will get the right caller to the right, resource or response.
Thank you so much.
Thanks. And another question came in from Dr. Ellison. If you want to say your question out loud, otherwise I'll read it.
Oh no, I'm here, and
Yes.
Thank you. I work in Delaware as a geriatric psychiatrist, and I enjoyed this presentation very much. I'm interested in how in your county you handle the problem of people with dementia and behavioral emergencies. Are they considered as psychiatric disorders? Are they detained for evaluation? Is there a special place where they can go? And what kind of training is included in the crisis intervention training about that topic?
So, Dr. Goldman, do you want to handle the first part of it?
Sure. I think that if I was going to say that the kind of special populations, if you're going to put a geriatric population in that category of like individuals with dementia, I think that group of individuals is one of the more challenging groups that when they're experiencing crisis, there's not a one size fits all best place. The current system. I think of also similarly with like those with intellectual disabilities, or I think that there's unfortunately, not enough of that kind of the specialized settings for individuals that may have outwardly kind of behavioral crisis needs, don't do as well or don't benefit from the same sorts of interventions that we have for others. I as well as understanding of the kind of current system. It depends on where they're coming from, who's calling, and the type of symptoms that they're experiencing. If it is one of potentially outward kind of aggression, or there's risk of harm to others, versus if there's kind of disorganization or confusion. I think that it sometimes varies. On the front lines in the EDs, oftentimes there'll be a screening of sorts to make sure that there's not an acute medical etiology, that they're not febrile, or there's some other factor that would be best treated in the medical, and then they oftentimes do get sent over to psychiatrist, or psychiatry gets consulted. But I think how that best gets treated, it's challenging, because the patients with dementia oftentimes don't do well on the inpatient setting, and it can also complicate the longer course of where their options that are available to them after the crisis if they've then spent time in an inpatient psychiatric unit. So I think there's oftentimes in the hospitals, at least, a real challenge around figuring out how best to meet their needs, both like in the immediate crisis and then, for the longer term picture.
Thank you. Not surprisingly, we're struggling with the similar problems in Delaware. And I wondered, Chief Tobin, whether the crisis intervention training addresses this at all.
We do slightly. To be honest with you, the amount of times that we come in contact with geriatric dementia patients is when they go missing, and we're dealing with the family trying to locate them. We have done extensive research, and I think New York is unique. We've also tried radio frequencies where, if a person had a tracker in their shoe, because I could tell you, I get dozens of messages about missing people in New York City every single day. But, if someone has a GPS tracker, you get to 545 West 57th Street and you look and you have a, 30-story apartment building. And radio frequencies work better there. But if someone enters the subway system, and it's also a matter of where you put it, is the person going to put that pair of shoes on, or are they walking out with their slippers on, and there is no tracking. So we do a lot of training in terms of how we can find people. But our first interaction, if we come across someone with dementia, is always first stop. It will be a medical facility to have them checked out. And then I think the right calls are made by health professionals rather than PD folks. Yeah.
Well, thank you so much. I appreciate your answers. Yeah.
Sure.
And one other question in the chat is from Dr. Jaffe. If she is still around. So her question was, as a psychiatrist, how can she get more involved in the issues of the homeless and mentally ill population?
I would, if you're asking me, I would welcome that, because I don't know if you know, but we got defunded by $1 billion in the last go around. And the first thing that was chopped was our homeless outreach and services unit. They moved all the money over to the Department of Homeless Services, who, it took the money and they hired people. I think I would have preferred the term reallocation of that money rather than defunding the police, because I think that there is a role. We send out officers for the 958 when they're doing homeless removal, 958s on homeless individuals, because what we're finding, it's not that the appropriate agencies don't want to do the job, but they want a police presence in certain circumstances. So I think that has to be addressed. But anyone who wants to get involved in that, I will leave that to Dr. Goldman, but I think there are plenty of opportunities, because God knows that I think we're at a crisis level in New York City.
Yes. Yeah, I would echo that. I think they could certainly reach out to me and I'd connect them. I'm sure Dr. Capasso also could welcome them with open arms and have many ideas of how to, make a great impact. So I think that, unfortunately, there is a lot of overlap and interplay between individuals that are struggling with homelessness and mental illness and those that end up then in crisis. They're the least sometimes engaged in treatment, or the least kind of willing or trusting to kind of engage with some of our more like systems-based care. So,
other questions, Dr. Kleinman? Oh, you're on mute, Dr. Kleinman.
Okay, can you hear me now? So I'm going to ask a question that is, I think, primarily directed to Chief Tobin, and it's not a question to which I expect a simple or necessarily clear answer, but I'm going to ask it anyway. Obviously, one of the challenges historically that the department has faced has been with either acutely violent, mentally ill people who are encountered by police officers, or those who are perceived as acutely mentally ill. And unfortunately, sometimes there have been tragic outcomes to those situations, although percentage-wise, I'm sure that is a very small percentage of the total encounters. My question is, in recent years, have there been any changes in the training and understanding of how to approach such individuals, understanding that there is no one individual, obviously, but that's something that I'd like to understand a little bit more about.
So the answer is yes. No,
Right.
It is yes.
My question deserved that. Yes.
We have modified training. So I think that it happens on a couple of levels. One is if we could make sure that people stay connected to care. I think the number of cases where the police are called because the person is decompensated will be reduced. So if we could do front end work, that would be great. Two is, I think that we have taken the approach where we're saying, slow things down. We have all the time in the world.
Good.
I mean, I come from a view of a doorstop. Someone's alone in an apartment threatening to harm themselves, no one else, then we could just keep an eye on you, close the door, wait for the appropriate resources to get there, and take our time to work that through. So we are focused on training in crisis intervention to just remind officers that, you know, time is on our side. So let's take it. But I do think that the collaborations between the police department and, you know, our health professional colleagues will go a long way in reducing that actually occurs. I mean, there are other models around the nation that I think we're looking at. You know, Houston does an EMT, a clinician, and a law enforcement officer, you know, as a team, because we know that Be Heard is responding to 22% of the calls. That still means, even at best, I think the hope is 50%, but that still leaves 50% of the calls where we know that the person either has a weapon or is violent, and that requires a police presence. What is the best group of people to respond to that, and how can we make that you know, efficient? Does that answer your question, Dr.
Yes,
Klein?
I'll just ask a quick follow-up. I assume that these different approaches are being subjected to research, and is there any outcome yet? Or I understand a lot of this is very early, but it's very interesting as to what will eventually happen.
I think one of the leaders who is having a paid study is the Houston Police Department and Dallas for Fort Worth, as well as Tucson and Phoenix in Arizona, where they're having programs similar to what we're doing in New York City evaluated to see how those outcomes have changed. But to your earlier point, the number of times that we get involved in an actual firearm discharge is less than 1%. So it's hard to measure against that. And that 1% includes people that have nothing to do with mental any type of mental or behavioral crisis. These are where we're encountering armed people shooting at us. So when you go to behavioral health, it gets even much smaller. So I think those are hard. It's hard to measure because the number, thankfully, is so small.
Thank you. Thank you very much.
One thing I was thinking about in some of these other programs, I know particularly in Arizona, that they're able to utilize is, if not like a paired response immediately, that there's real-time kind of cross-collaboration, because, sometimes officers may not know, 911 call takers don't know when a call comes in, you get just such a small snapshot of what actually is happening on the scene. And so I think some programs have been very successful in when an officer arrives and gets a better sense of what's happening, they're able to quickly call, for example, like a behavioral health then response team or a support person that can come, or utilizing technology in some ways. And I think those are, because I think that's the other challenge, the size and complexity of New York City in being able to create any of those kind of collaborations on a large scale. So, I think there's a lot of potential out there. And so I think it's great that it's being explored, and then trying to then right size it and think about the logistics and the technology for here to maximize it will be really important.
And I'll give as an example, and for people on the call, I'm assuming New York, but I know Delaware is on. We had a suicidal male outside the UN who for 2.5 hours had a shotgun pointed, at his throat. And, we took the time, but there was a wonderful dialogue. But that's a situation that would have been horrible had we shot him, because it would almost be suicide by cop. But if he had turned that shotgun and aimed it at officers, it's a very complex situations. And I think circumstances vary greatly.
Danielle,
Yes.
can I have a follow-up to that?
If it's related to that, I do have one other question in the chat. So go ahead, Dr.
You talked about, just raised the issue of somebody with a shotgun in front of the UN. I'm a forensic psychiatrist, and I do most of my work, or at least initially, within the criminal justice system. So I see people afterwards, but I've seen a number of police officers as well. And one of the things I've gotten from them is the trauma that they experience. And I'm focused on trauma a lot. And I have two questions, sort of. What does the department do to deal with the trauma that police officers experience? Because it's much more than just a particular incident. Mm-hmm. Everybody who goes out in some ways each day goes out with an anxiety that maybe something will happen. And they face that every day. And that builds up. It's like some of the stuff that's happened here in COVID, where people go out fearing there's something out there dangerous, and it is manifested in increased mental health. And the second thing I've heard from officers is that they're afraid to go report their problems because they feel if they do, it's going to interfere with their moving forward in the department. And It seems to me the opposite thing should be happening, that the department, if it sees somebody going in some kind of trauma situation, ought to mandate that every one of those officers goes in for an evaluation. I wonder if that's being done or not.
Sure. Very briefly, we are addressing that because we had a spike in suicides.
Yes.
So one of the, I think, really wonderful programs being received right now is when people are involved in traumatic experiences, whether it's a shooting, but like that was always automatic. But I'm talking about, the officer who responds in an apartment by abusive parents, those officers are now called down in groups, and they are debriefed. So they have an opportunity to talk with a wonderful psychiatrist that we have on staff, and there's no record keeping. This is not our psychological services. The other program, and I've been part of it since 2000, is called PAPA. It's police officers providing peer assistance, and it's for people who have exactly that fear that you're speaking about, that if they come forward, they're going to wind up losing their job, or their gun and shield is going to get taken away. So they can call a number. And like I'm on it's an old fashioned, but you probably all can appreciate it. It's a beeper system. So you call a number. If I'm on, my beeper goes off, I call it. And then sometimes, honestly, I call the number and the person says, "Hi, this is Mickey Mouse and I'm at 516 blah, blah, blah." And then I call him like, "Hey, are you Mickey?" He says, "Yeah." And then I arrange a meet. I explain that anything he says is confidential. And then through this organization, we have different health insurance providers in the mental health field that have agreed to see officers on an expedited basis, and they will accept the insurance that the officer has.
So thank you. In the interest of time, I know we just have a couple of other questions. Let me just hit one of them with Dr. Solkani. If you're still around.
Hi, can you hear me?
Yes.
Hi, sorry, I'm calling in from my phone. I'm not able to do the video at the second. Sorry about that. I'm actually part-time at SCC right now, so I was going to ask a little bit to Chief Tobin and Dr. Goldman. When the program first started, I kind of saw it more as a geared towards like a pre-arrest intervention sort of model. Meaning that if someone's getting picked up for something minor and it turns out to be a mental health issue playing out, that's a good candidate for SCC at that time. Mm-hmm. Now, as SCC sort of progressed, we're collaborating with Be Heard, and now we have a third category of clients, which are self-referrals, meaning guests who were there, completed the program, left, and now they can self-refer, right? So something I was curious about is because I think the Be Heard client is more of a pre-hospitalization intervention, almost trying to prevent a hospitalization, versus an NYPD referrals can sometimes be a pre-arrest intervention, and then the self-referral can be a very mixed bag. So it could be I just need a break, I'm tired of my housing situation. It could be a detox situation. So I was kind of wondering, like, what's both of your take about an ideal SEC client and what's an ideal goal for an SEC client? And that way we can look at a measure and see if it's hitting that ideal target.
Dr. Goldman, do you want to speak first?
I think I would love to hear more about your experience, actually. I mean, maybe at another time, just to hear about differences or similarity. You highlight a little bit of some of the different needs that individuals might be having if they're self-presenting. But I was just, I'd love to hear more from your perspective of those differences and of the benefits that you're seeing from their stay and, how that. I mean, I think that for the larger crisis stabilization center, like future directions, I think the idea is to be open to all of the above. And if it sounds like if they may need to be willing to wear a number of different hats and meet a number of different needs, given the different kind of states or the states that individuals might be coming in, depending on how they're being brought forth. I don't know. It's a very interesting question. Similar, like to when I think of CPAPs, the individuals that bring themselves in versus are brought in involuntarily by EMS versus those that are dragged by their family, kicking and screaming, is very different kind of initial interactions and engagement strategies that you use. I don't know, Chief Tobin, if you have thoughts for that question.
I too am interested in hearing more from you, Doctor, but I think it is low-level arrests that are avoided. And I have to say this, we need them to be volunteer to go with us. We can't say, would you like to go to the support center and have that or hanging? It can't, that's not, it would be considered by the courts coerced. So we're not allowed to do that. And as you know, we have body-worn cameras. So we try to capture that. In fact, we are bringing someone voluntarily. But I would say what brings that person to our attention most often is because they are committing some type of low-level offense, which may be violation, maybe rise to the level of misdemeanor. But I think that the officers know that this is not a criminal sanction, will not suffice, that it would be so much better if we could connect that person at the support and connection center.
Thank you very much. I know I apologize. I know we're at our 15 minutes of questions. I do want to be respectful of everyone's time. But I know this is a conversation that could continue for a while. I want to thank you again for your great presentations and for taking the time out of your busy schedules to talk with us. If you guys, I wanted to ask you if you did want to share your email, if anyone had further questions, to reach out to you, if that's okay. You could either reach out to me, I could forward it over, or we could reach out to you directly. Maybe you could share that in the chat.
Okay, I just put mine in there, and I just, it has jumped, but there was a question regarding human trafficking and prostitutes. And the NYPD does not arrest prostitutes. We're more focused on the offenders of, the Johns, unless there are certain criteria where we think arrest is the only way that we can bring them in, but they are always offered services. So I wanted to let you know that that was a change in our own policy.
No, thank you for answering that quickly. Dr. Kleinman, do you want to add anything else as we wind down?
No, I just wanted to again thank the speakers, and I think that change is accelerating, and I think there are opportunities to do things in innovative ways, and I'm impressed by what I learned. So thank you both, and thank you everyone for attending tonight.
Great.
Thank you for having us. Much. And if you're interested in the forensic committee through NYCPS, please reach out. We're happy to have you join.
Okay, good night.
everyone. Have a great night.